So welcome to our April Fireside chat. We've got one of my favorite guests, although I don't have Peyton Manning to kick this thing off, but we got Ryan Work with SIIA joining us. And he is always not only very educational, but completely entertaining at the same time. And joining him is 6 Degrees President Katy Brant. And I think there's going to be some dialogue around, some of the legislative changes and the impact that has on cost containment and big claims. And so she'll be working in some of that. And as always, please ask questions through the chat function. And for those of you that are new to my little lecture on this, please use the Q&A tab at the bottom of your Zoom browser. There is a thing that says chat, but that is hard for me to follow. The Q&A actually puts the questions into a logical order that I can answer and click away once we've answered them. So with that, let's do a quick little introduction here and go forward a slide. Oh, there's the agenda. So I think I hit on all that, but let's go to the introductions here. There we go, Ryan Work. Ryan, as I mentioned, comes out of SIIA. We had the pleasure of meeting several years back at a speaking event and kind of hit it off at that point and have become friends since, and been very fortunate to have him do these fireside chats for us and some of our conferences. But like I said, he always brings just a great knowledge base in what's going on the Hill and the impacts that has with what we're doing as an industry. So happy to have Ryan here. Thank you very much. And then Katy. Yeah. And then there's Katy and her smiling face. But as I was joking earlier about my medical expertise, that was a complete joke. But Katy does bring an incredible level of experience in large claims, and her background in nursing and all that is something that she's applying to 6 Degrees cost containment solutions every day. And so happy to have Katy here joining us. And with that, let's kick this thing off. I'll turn it over to the experts and let them do the talking for a while.
Yeah, so I think I really want to talk about what's going on in the Hill right now in terms of politics and healthcare and everything that's going on around that. And part of this has to do with just the politics of the Hill, right? So one of my, the first things is there's a hugely widening gap between what the base wants and I think like what the mainstream part of America wants. And we're seeing that fight play out on the Hill. And, Congress has been very interesting lately. It's a new political divide, right? We have a Republican House, a Democratic Senate. They're actually, we're now exactly 101 days into the new Congress. And we're still seeing people organize. We're seeing committees still trying to figure out what they want to do. And they're all playing to their base. And especially in a Senate that has a 51-49 majority, let me tell you this. I mean, on any given day, one of the things to remember in the Senate is Senator Schumer, the majority leader from New York, has a specific agenda, wants to put forward judicial nominees, wants to have a number of things. It's hard when you have any single senator absent. And right now you have several absent. You have Senator Fetterman from Pennsylvania, who just came back after literally several weeks, several months away from mental health issues. You have Dianne Feinstein from California, who's aging, who has shingles, who has been in California for months, and asked last week to have her spot on the Judiciary Committee filled in her absence, which, by the way, needs Senate approval, and the Republicans don't want it. And so you have all these things going on that are literally putting the Senate at a complete standstill. And that's what you get when you have a slim majority, that one or two senators, whether they're sick, whether they have a death in the family, anything could happen, and it puts that entire Senate process at a standstill. And I don't think a lot of people understand that and what the dynamic is going on that. And even at the committee level, Feinstein being out at the judiciary actually means that not even the Senate Judiciary Committee can pass through nominees. And maybe, the question is, well, why do people in healthcare have to care about that? Well, think about all the healthcare, topics that are up at the federal court. I mean, and I'll talk about this later, but we have 16 federal court cases right now on surprise billing. And so think about how important the judiciary is on the future of healthcare and what all these things mean to people. I think the last thing I'll say on politics and healthcare is to give you all an understanding of what's going on in the committee. So, we can't be everything to everybody, but what we can do is focus on the 4 or 5 committees on the House and Senate that matter. And that's exactly what we do. So, let's start with House Ways and Means, right? So I was a Ways and Means staffer on the House side, primary jurisdiction over healthcare, trade, a number of different things. But interestingly enough, we have a brand new chairman at Ways and Means. He's from Southern Missouri, doesn't have a city in his district. And that's very important for how we and others interact with Ways and Means, because we have somebody from a very rural background. And I think from a very positive perspective, he's coming at healthcare with a rural perspective, right? Delivery, access, cost, and rural hospitals serving their communities. And it's very different than what we've dealt with before. And it's something that we have to be cognizant of and frame our issues correctly. On energy and commerce, Heath, close to where you are, and my former boss, Kathleen Morris Rogers, is from Spokane, Washington, from Eastern Washington. She's very pro-employer, understands the impact of surprise billing and arbitration. I think wants to really support small and medium-sized businesses and what we're all doing in the self-insured space. So I think we have an ally there. On workforce, Virginia Fox, she's from North Carolina. We're actually going to have, I was just on a call with the staffer right before this. We're actually going to have a hearing next Wednesday. Put this on your calendar. We're having a hearing that I think is actually going to have some consequences for all of us. We're going to have a new iteration of the Self-Insurance Protection Act that protects stop loss from state regulation. We're going to have a bill that has that produces grants for TPAs for value-based care. And so we're actually, education and workforce is really pushing some issues that are close to all of our hearts when it comes to strengthening and improving the self-insured world. And then with that all said, I'll move over to Senate Health, which is the Health, Education, and Labor Committee. So we have Bernie Sanders. Everybody knows who Bernie Sanders is. He's the chair of the Senate Health Committee, wants Medicare for all, right? The ranking member on health is Bill Cassidy, who's a doctor. And that's an interesting dynamic when it comes to things like the No Surprises Act, because he's coming at it from a very pro-provider standpoint. And so if anything, we really have our hands full when it comes to the Senate and the kind of the Medicare for all dynamic, the provider dynamic, and what that means overall. So I think from a political standpoint, Heath, I'll kind of leave it at that. Interested in kind of any feedback or questions or thoughts people have on what that means for the self-insured industry.
Yeah, folks have questions on in the audience, feel free to type those in. I mean, I guess selfishly from our perspective, what impact do you see these committees and the work that they're doing having on not only the self-insured, but reference-based and cost containment, and specifically?
Right. So I was going back to the committee hearing next week, and I think I in talking to committee staff, I think one of the things we see over probably the next couple of weeks for the very first time are oversight hearings on price transparency and how hospitals, provider groups, employer plans are dealing with this. So what are the burdens? What's working? What are the challenges and opportunities? And as we all know, especially at 6 Degrees, there's a lot of good opportunities going on for claims analysis, for cost containment. And so, one of the biggest things coming out of this, and one of the things that we should all be proud of because we're all working towards this, is patient protection. At the end of the day, patients are being protected. That's the absolute most important part of this. And I don't want anybody to lose sight of that. And so, at the same time, we're all in the trenches trying to figure out, okay, the patients are protected, but how do we implement this correctly? There's administrative burdens. And on your end, especially like when we'll talk about this in a little bit, like on Katy's side, like, hey, how does this impact what we do from a cost containment perspective for our clients? And I think it'll be interesting to see how Congress views that in light of, patient, provider, insurance employer, witnesses as some of those oversight hearings go on. Because at the end of the day, Congress did all this thinking that the individual, the patient, would understand all this data. And the fact is, there is so much data that you and I, the three of us, can go into a hospital, get a bill, and we don't even understand it. We're in the business. And the average consumer, who, all this legislation is meant to impact, doesn't understand and cannot consume this data in the right way. And I don't know how to address that. That data is hard for us to understand. At the end of the day, Congress wanted this to be about consumer choice. And at some point we may get there, but I think Congress is going to understand very soon that what they intended isn't happening because this data is overwhelming, it's complex, and the average consumer needs that distilled on a much finer basis. Well, at the same time, it's interesting for all of us because we can see this data and utilize it probably in different ways to help out employer plans, do that cost containment, understand what they're paying in a better way. And for that matter, maybe negotiate, especially through like an RBP plan for a better price for a lot of these plans.
Yeah.
Super long, short question.
Yeah. Well, okay. So do you think, they recognize that, some of the people they think should be playing nicely in the sandbox are working against them, networks, carriers, providers? I think there's a lot of money in healthcare, and having it work right may not be in everyone's, primary.
Yeah.
interest.
Let me say a couple of things on that. I was actually looking earlier today. There were new numbers out on US healthcare spending. And one of the things that struck me personally was if you look at the US versus other OECD countries, right, developed countries, we have the worst health rates in the entire world when it comes to birth rate, when it comes to dealing with important things like mental health and suicide, preventative care, heart disease, obesity. But yet we're spending think about this, we're spending 4 times the amount of money in GDP that a country like South Korea is, but have less health outcomes. And so to me, this is really about how we take that data, because it's not good data, and how we improve our policy performance on it. And going back to your question, the one thing I'll say is that I think in the next couple of weeks, we will see probably a package out of the US Senate on drug and pricing and other reforms. Part of that is going to be network adequacy. Part of that is going to be looking at provider directories and network information, ensuring that patients and plans have everything up to speed. But I think to your point, that also takes a massive amount of coordination between all the participants in that consumer's plan. It takes work from you, right? From employers, from providers, to make sure that every part of that information for consumers is up to date and correct, because that's what Congress is expecting to happen, thinking that that will somehow improve efficiency and consumer choice and decisions kind of within our complex and largely messed up healthcare process.
Are you hearing anything on the PBM drug pricing front? I know that's of interest to a lot of folks on this call as well.
Yes, so I'm glad you brought that up. And actually, it's funny because Keith and I didn't really even talk about this ahead of time, but the PBM and drug pricing space is probably one of the biggest debates going on the Hill right now. And we're also seeing it on the state side, which I want to address. So if one thing comes out of Congress in the next year or two, it's going to be on PBM and drug pricing reform. I feel very confident about that. Already this year, I was talking about congressional committees earlier. Senate Finance has already heard and marked up a PBM bill. Senate Health has their own PBM bill on transparency, spread pricing, reporting, making sure that people understand whether a PBM is referring to a PBM-owned pharmacy, for instance. And I actually saw a draft bill on Monday in the Senate, but I think in the May-June timeline, we will see a PBM drug pricing bill in the Senate that could very well move, which is pretty amazing considering there's a 51-49 split. But this, from my understanding, this PBM drug pricing bill is going to have 4 components. The first is going to be insulin cap at $25 co-share, like co-payment for a patient in a month. It's great for the patient. It's bad for plans because that means manufacturers can increase insulin prices as much as they want, and the plan is going to be responsible for it. The second part of that is PBM reform, and I talked about spread, preventing spread pricing and things like that. And I'm trying to remember that the third part is basically patent reform and making sure that a drug manufacturer can't file a patent, 200 patents for a single, formulary to allow for generics entering the marketplace. And the fourth has to do with ghost networks. I kind of mentioned it before, but it really has to do with mental health and other things. But those ghost networks are really about making sure that provider directories are up to date. It sounds like a good thing. What's bad for small and medium-sized self-insured plans, though, is it's very hard to get that information from a provider to update those directories every 30 days. It's just not possible. So I think the Senate is going to be focused on that in the next couple of months. I think it's going to pass. I think Schumer is very focused on it. I don't know where the House is going to go, but I do think the House is also focused on very similar PBM issues. So end of day, Keith, to your question, drug pricing is huge. I don't think this will address all of the issues that we have, especially since we're dealing with these hugely high costs on the cell and gene therapy side. I also personally don't think that, PBMs may or may not be a problem, but it's a low hanging fruit from a policy perspective, but it's not really going to solve the larger issues that we're all facing from a cost containment perspective, right? So, but it's coming. It's going to impact plans. And let me end by saying this: states are all in the wake of the federal government not doing stuff. The states are looking at PBMs, and we've been fighting some large battles in places like Louisiana and Texas that have taken a Supreme Court decision in Rutledge and started eroding ERISA preemption, because states like Louisiana and Texas have introduced legislation that says, well, Rutledge went so far as to say we can start regulating ERISA plans because of PBM benefits. And from SIIA's perspective, we have a problem with that because it starts eroding that ERISA firewall between state and federal, and it's dangerous. And I think we've put them off, but it's a new battle that we're going to begin to fight, and I think everybody needs to be aware of that.
Hey, got a question that came in specific to this drug conversation. Any talk on the Hill about international prescription drugs, specifically allowing employers to procure drugs from foreign countries?
From a place like Canada, right? There's always a larger discussion about that. I think that's a lot more complex, and Congress is doing what it does best, which is picking low-hanging fruit. And so I think that there has been a long ongoing debate about what this question is about, which is about drug reimportation. And by the fact that you can, here's the crazy thing, Heath, you can go to Canada or Germany and you can get the same drug that you get in the US for half the price. And the question is, or even a third. And the question is why? Because it's not because of government subsidies. And so there's that out there. I don't think Congress is in a place to tackle that now. I think that potentially going to happen, but it's a lot like a number of other debates in Congress. It takes 3, 5, 10 years to get there. But the fact is that, we know people go across the border to Canada, they get their Molson Triple X, and they get their prescription drugs for cheap, and they come back across the border. So it is what it is.
Beautiful. All right. Well, we spent the first 22 minutes on the first slide. Should we go on to price transparency?
You go, yeah. Yeah, and Heath, I don't know if you have specific questions on this, or you kind of want me to go through, kind of what we're seeing on surprise billing and price transparency.
Yeah, why don't you give us the Ryan work version, and then I've got a couple of questions that I build in that.
Yeah, listen, I mean, I think, this slide's really about the No Surprises Act, and it's something that Heath and Katy have been immersed in and have given us a lot of feedback on throughout kind of the process, especially when it comes to reference-based pricing, right? But a lot of you that know about the No Surprises Act know that the end game is arbitration. It's a baseball style arbitration. It's where you don't come to an agreement in open negotiation, and the provider and the insurer, the employer, go into an arbitration process. Now that are over a year into this, what we've seen, and this is I won't talk through all this slide, but what you'll see, the data from CMS and the federal agencies, is that arbitration is being utilized exponentially more than the federal government ever thought about. So think about this. There were 9 million surprise bills in the first 9 months of the No Surprises Act, and there were 90,000 out-of-network payments. Initially in their rule, the federal government thought that there would be 17,000. So that leads us to believe a couple things. One, the system is overwhelmed. 2, on top of that, think about this. You have 90,000 claims. The federal government thought there would be 40 to 50 federal arbitration entities. There's 11. As of today, there's 11 to 12 federally approved arbitration entities, doing 90,000 claims. They're overwhelmed. They don't know how to do it. And on top of that, right now we have 16 separate lawsuits from providers against the federal arbitration rule. And what that means is that the way these arbiters look at arbitration changes on a monthly basis based on these court decisions. And it's changing things like the qualified payment amount, how people dictate what their reimbursement rate is going to be, and the factors in that. And so that not only makes confusion reign for us, but it especially makes it confusion reign for the 11 arbiters that are operating in this 90,000 space. Now, the other thing I'll say in this argument is that a huge percentage of these claims going to arbitration aren't actually qualified to even be NSA claims. Some of those need to be on the state level. Some of them aren't even NSA claims, because remember, to be an NSA claim, you need to be under 2 factors: emergency room or going into an in-network facility with an out-of-network provider, like an anesthesiologist or radiologist. And so what we're also seeing is a huge number of claims going to arbitration that should never be in the federal process in and of itself. And so that's part of the overwhelming nature of it. And then the last part of this is that you see a very small percentage of providers and companies that are filing, look at that, 75% of disputes. And so what's fascinating to look at this is to look at the regional numbers, because I've talked to providers, for instance, in North Carolina, that never go to arbitration because they have a good relationship with their local provider networks and their hospitals, and they agree to agree. But that's few and far between. And so what I've seen in the industry is that it really depends on where you are and what type of claim you have in terms of the outcomes and the complexity of what's going on here. And when it comes to RBP, I think that's even more complex, because remember, in an RBP network, there's no network. So while you are covered under the emergent part, of the No Surprises Act, you don't have to deal with that second part, which is having an in-network provider with an out-of-network, tertiary care provider, which is kind of a blessing in and of itself, right? But it also puts some complexities around RVP and then how you come up with the QPA.
Can you kind of dive in a little deeper on the impacts of the No Surprises Act and transparency rules and how that plays out with RVP?
So for RVP specifically, RVP is just a unique factor in the No Surprises Act, and here's how I've always couched it. And I remember going to the White House 4 years ago or 5 years ago now, when we first had discussions about the No Surprises Act, is that staffers in the administration on the Hill have always thought very clearly, black and white, between in-network and out-of-network. And it was a huge uphill battle for us to explain to them about RVP, because it confuses them, right? Like you get out of the two lanes of healthcare and it confuses staffers. It is what it is. But I think where we were successful is to make them understand how RVP is being utilized for people in the right way and how it's reducing cost and claims. And I think they're getting there. But what the challenge with the way the NSA was written, again, kind of going back to my previous comment, was that there's no, RVP is only really impacted by half the NSA. And then on top of that, you layer in the fact that you can't have, if you're using like a Medicare pricing system, you can't actually utilize that within the NSA, which then requires a database of claims for you to utilize, right? And that's really the key and the mystery within RVP, and then utilizing that to come up with that qualifying payment amount, that reimbursement amount for that emergency care. And I know it's something like you're super cognizant about and working, and I think the rate you're going through that and helping to avoid arbitration is a really good thing.
Hey, Ryan, when we were at SIIA, I thought it was really interesting when the regulators were on for that session and talking about the confusion of applicability, and, we're open to feedback. Has there been any more conversation around that? Because I think it's interesting, right? When the people that are putting these regulations out there, like, yeah, we really didn't know how it was going to go either. So
right. Yeah.
Maybe touch on that just a little bit. I thought that was really interesting.
Yeah, well, that's a great question. We have two dynamics going here, right? We have Congress, who is writing this, and I would never really want to be an agency staffer, because like Congress, and listen, I was a staffer, I get it. They write these things ethereally, and then like kind of, they're not well written. They kind of push them together and they pass them, and they throw them over to the agencies and they say, good luck and Godspeed, and it's going to be great.
Right.
And so you have the agency staffers that that we heard from, Katy, and I'll be honest, like I have so much respect for them, because they're doing the brunt of this work, and it's not easy. And we are quick to blame government bureaucrats, and I do all the time, believe me. But the work that I know these agencies are doing to try to do the right thing and to stand up price transparency is really impressive, considering the lack of resources they have. And we have conversations with them all the time about the challenges we face. And the one thing I've been very impressed about with price transparency specifically is that they're very open to hearing those. And they've been very quick to try to at least go down the road of trying to solve that. And that goes to a number of things in price transparency. It's about making sure that there's, the portal operates better, that we understand the claim, that we have the correct contact information, that we have the correct codes, that we're flagging ineligible claims before they go to the open negotiation or the arbitration process. And so it's not a perfect system. I think they're working very diligently to come up with a better, especially online system for all of us to kind of navigate through, and that may take another year or so to happen, but I think we're all going to be better off for it. But I think the point that you're making is that they understand, they're listening, and they're trying the best they can to implement change where they know that change needs to happen.
Hey, is there any discussion at the powers that be around the increased costs from some of these things? You know, the IDR fees increased from 50 to 350. You got MRFs and all the, you know, there's this underlying thing that's kind of a side effect of what they're trying to do that is increasing the administration costs and of doing business.
Absolutely. It's something that bothers me a great deal. It's actually something that we talked about in the very beginning, is that, look, at the end of the day, you're hoping that price transparency has a positive impact on the cost of healthcare. Because really, it's price transparency is really about two things. It's about protecting the patient, and secondarily, it's about bringing down the cost of healthcare that has to be brought down, or else it's going to be unsustainable. And my concern especially from the self-insured world, is that, you know, you mentioned machine readable files, right? We're under all these different price transparency mandates. What Congress never even thought about, Heath, to your question, is the cost and administrative burden that this has, especially on small and medium-sized plans. Because if you take any single one of these silos of price transparency, machine readable files, drug reporting, air ambulance, AEOBs, which we haven't even gotten into yet, each and every one of those has huge administrative and overhead costs. And the fact is, I don't think Congress understood that at the end of the day, a lot of that is probably going to end up on the consumer, regardless of where that is. But it also has a huge cost implication for vendors, for employers, and for TPAs. And so let me put that aside, because I totally agree. And then you bring up, for instance, the cost of going to arbitration. So the agencies technically have authority to dictate the cost of arbitration. They just this year decided to increase that to $250 per arbitration claim. And there's two things about that. One, the providers immediately filed a lawsuit and said that they don't have the ability to do that. And I'm not sure that they do. I don't know how the courts are going to decide on that. But my other point is that the more expensive arbitration is, the less likely providers are going to want to go to arbitration. It's actually why we actually try to advocate for a baseline of when you should have an NSA claim, because at some point your NSA claim is going to be so low that it's not going to be worth the administrative hassle, if you will, and the expense to even go through this process. And so honestly, part of me wonders if that increase in cost to go to arbitration is going to help set a floor for providers and employers about when and if they should be going to arbitration in the first place. And for some reason, when we were advocating on the Hill and with the White House, I always had this thought of having this $5,000 baseline, because I don't think a claim below $5,000 is even worth going to arbitration about. But I just came up with that ethereally. I don't know if it's right, but I've always thought that way, that at some point it's not worth it for anybody to go through that entire process, the hours, the expense, and everything else to deal with a claim that's below that number.
Yeah, we have a lot of clients that are setting those thresholds because it just doesn't make sense. I mean, even just the claim being maybe the same cost as the arbitration, you know, you're still losing there. So yeah, we've got that. We're seeing that.
Yeah, that's a great point, Katy, because, you know, I talk to people all the time is that, look, you know, just because NSA does something doesn't mean that you shouldn't have an internal strategy, right, about how you should be dealing with this. And so when I give that example about that threshold, like, I'm sure plans have that have a threshold that they've strategically thought about, in addition to how they want to do open negotiation, including how they want to strategically enter into arbitration. And it's super smart for people to have that strategy, and more importantly, to communicate that with all those plan participants, right? Because at the end of the day, that strategy is largely up to the employer, but that employer then needs to have those conversations with every part of their plan about how they want to deal with that. Because at the end of the day, that's going to dictate the administrative expenses and the time and everything else that we just talked about.
Yeah.
So we've got a couple questions coming in from the audience here. Do regulators actually understand the concept of pricing healthcare? What is their reaction to hospitals charging 8 to 10 times Medicare?
It's a great question. I mean, that question you could get rid of regulators and just ask that generally if anybody really has a good sense of the cost of healthcare. I think regulators are truly trying to get their hands around it. And I think that they feel like the NSA and some of these price transparency measures help them out, because remember, we have a hospital price transparency rule. We have machine readable files. We have the NSA, and all this data together at some point, 5-10 years from now, is going to provide us with more data to help us understand healthcare costs. I don't know if I want federal regulators to actually get involved and understand the cost of healthcare necessarily. I don't want that to sound bad, but I think they're trying to get their head around how they can best set up the system to understand it better on their own. And then when it's within their regulatory power, figuring out who's being abusive or not. And I think this is kind of the start of that, but it's so complex, right? It depends on a lot of the things that we're seeing in the NSA about acuity and where you are in the regional part of that, right? I mean, this is what makes healthcare so complex. And I think part of these solutions really need to be in the private sector versus thinking that the federal government's going to do it for us. Because if you go down that line too far, you all of a sudden butt into this debate about, government run healthcare. And so a lot of me thinks that it's best that we and the providers work together to do that on our own.
Well, Ryan, I mean, you and I have talked a lot about this, right? So just looking at their hospital charge masters, right? So what did you say? 15% of hospitals are compliant with publishing their charge masters. But if you get in there and look at them, there's no way for a layperson to understand what these charges are, whether they're appropriate, whether the markup is 8 times or 100 times their cost. We see that frequently on our bill reviews where pharmaceuticals are marked up 8 times on one drug and 100 times on another. And without getting really into the details with a lot of experience, you can't put these things together. So the transparency part is great, right? Step in the right direction. It's the understanding the data and the information that is transparent. And I think you're right. I mean, I would argue heavily that needs to stay more in the private sector and, get the experts, because it's just too much information, too challenging to understand.
And you bring up a great point, Katie, is that, the fact is that these prices that hospitals are putting out are up for, we all need to understand what that means. I mean, we may know better than the average person, but the patient doesn't. Because just because there's a charge master, we all know that nobody ever pays the charge master. And if you do, you don't be in the business, because these hospitals are artificially inflating these prices, and then patients see these and think they're getting a deal when they're actually not. And it's also to their credit why Congress and the administration were doing the NSA, has eliminated and prohibited the use of charge masters and other things and billed charges, and is focused on paid claims. There's a huge difference between those two. And it's also why you can go to any city and look at 3 hospitals in a single urban area, and they're charging vastly different prices for basic procedures that could be, hundreds of thousands of dollars different for something that, should be a lot lower. And that's part of the sick and needed solution to healthcare costs.
Yeah. Well, and these payments are based on, a bundle procedure as well. So, if you happen to wind up in the hospital and you're getting multiple services and multiple procedures, there's no way to know, did they bill that correctly, right? Are all of these things supposed to be on the bill together? Are they billing the procedure and all the things that should be a part of that procedure?
Right.
So, it's just, tip of the iceberg, right? But a much deeper level of understanding and sophistication has to come out of this. You know, as a start with, here's the transparency, now what?
Well, and Katy, you deal with this a lot more than I do and have tools in place to solve the solutions. But I heard a case last week where somebody went in for a physical and they were sent down the hall in their physician's office for blood work. All of a sudden, they got a $2,900 bill for that blood work. That blood work, you know, you and I go, you know, for blood pressure and everything else. It came out to an out-of-network hospital facility fee for that blood work, by the way, that their in-network physician sent them down the hall for. And then they charged a facility fee for every single 12 part of that blood work.
Right.
And this is exactly, you know, I saw this and I heard about it. And I'm like, this is exactly what's wrong with our healthcare system.
Right.
And it's something that I think you have the tools, for instance, to flag and to help plans deal with. And to me, like, that just exacerbated the whole issue going on with, you know, the charges and the absolute complexity and nonsense that's going on in fees and healthcare costs.
Yeah, I mean, just simply the point of care, where you're getting it, changes the cost entirely, right? If they did it right there in the doctor's office with the medical assistants they have on staff versus sending them down the hallway to an ancillary service where it's billed out separately. I mean, you know, it's wild.
All right, guys, I know that we have a whole section dedicated to Katy, but we are running out of minutes. So one quick question, Ryan, before we go to the next slide. So keep this short, but I like this question. Of those 10 companies that initiated 75% of all the disputes, are those companies associated with healthcare, or what's going on there?
Yeah, so off the top of my head, some of them are, and some of them are simply vendors for hospitals that are dealing with the arbitration part of that. So what we have is really a mixture of larger healthcare providers, most of them in Texas, and then vendors that provider systems are dealing with to help handle their QPA like the QPA calculation and the arbitration process.
Okay. All right. Onto the healthcare claims and hospital claims slide, transparency and SIIA provisions.
Yeah, no, I mean, we don't have to actually spend a lot of time on this. This is just really to help people understand kind of what's effective now and what's coming up. And I'm not at all gonna go through this, Keith. Like for 20 seconds, I'll say this. There's been enforcement delays on a couple of important things. So prescription drug reporting in the machine readable files, advanced explanation of benefits, and air ambulance reporting. A lot of these still have lawsuits against them. But what I continue to tell people is, because these are delayed does not mean you should not start looking into complying with them. Because all the time I get these questions from people like, well, these are delayed, I don't have to worry about them. That's not the truth, because before you know it, the agencies are going to have guidance related to these. People need to start looking forward to complying with them because they are coming. I think what the agencies are doing is they're overwhelmed. Look at all the stuff they've already done. These are some of the most complex parts of that. AEOB, air ambulance, which is in and of itself a whole different world. And you know, I'll be honest, like, we're also even talking about including ground ambulance and NSA at some point, right? Because that's full of nonsense. But the last thing I'll say is those several items under enforcement delays, don't forget those. Be involved and start looking at how you're going to comply before it gets too late, because those will pop up in the next year and a half. And it shouldn't be a surprise to anyone when they are.
All right. Next slide.
Keith, I'll probably just make a few points here because I know we're short on time and want to open it up for questions at the end. But you know, I think we've talked about the shortcomings maybe of all this transparency and the regulations, but we are seeing some good things coming out of it, right? Like, we know that this is a step in the right direction. There's been a lot of scrambling, certainly on our side, to help with solutions for applicability of the transparency. And, the machine readable files, while they're kind of a nightmare and they're very challenging to work through and actually translate into usable information, they have been helpful for us on the 6 Degrees side when we're looking at balance billing, and we're able to kind of leverage some of the information that we're getting, as well as contract negotiation, right? So, when we've got the median rates and then the reimbursement and the negotiated discounts, that's very helpful for working on behalf of our clients to get, a fair deal, to get a better deal, and to ultimately resolve balance bills that I think, outside of the QPA and the entire IDR process, just your average balance bills that we get every day. So, high points on that. I'm looking forward to it getting even better as we kind of work through this. But I think those have been some good components that have come out of it. In terms of, how plans use the data, there's shoppable procedures out there. It's pretty limited right now. And we've talked about this, like, if it's not on that shoppable procedure list, and, if unfortunately you get admitted to the hospital, we really feel like the next step of this, and part of it, is how do you use this to know what you're getting in that sort of situation, what you're getting out of that stay, how is your bill put together, and is it right? So, good steps in the right direction. We're talking about it more. I think this gives us a little bit more advocacy and remembering that the patient, the consumer, is at the heart of this. And so, employers, insurers, the providers, at the end of the day, we're all forced to be consumers of healthcare. And so we want this, right? But we're also, I said this at SIIA, consumers are lazy, right? I can say that because I'm a consumer. I want something on my phone, and I want it at the time of care. So I could be at open enrollment, I could be given all the information that I need, all the education, but I forget it as soon as I walk out the door. But when I'm faced with it, when I need that shoppable procedure, I need something that's going to be easy to use and easily accessible. So those are the tools I think we're all needing to kind of work towards, so that we can put all of this to work for us as consumers. Now, whether long-term this actually helps to, slow the growth of our $4 trillion healthcare problem, or whether it just helps us to be more informed, a big question mark in my mind. And, Ryan, I think we've had some offline conversations about it, but, right ideas, right direction, a lot of work to do. And I think that's really what we're focused on is, what's the next thing we can do to drill this down to the consumer better, so that we all feel some positive impact from it.
Hey, Ryan, is there any discussion around that with the folks that you're, running into about the actual consumer? I mean, I think sometimes that's lost in this whole discussion.
Yeah, I mean, again, Katy, you said it very well, and I couldn't agree more. Talked about it before, is that I think that there's probably more conversations going on within the industry about that consumer usability than there are probably in policy circles. I think, Congress is often of the opinion that, we wrote this, we passed it, like hands are, we're done, we're going to pass on to the regulators. It is what it is. I don't know. I will be interested in what comes out of some oversight hearings coming up when it comes to that consumer impact. But the fact is that we're seeing we are seeing consumers being actively protected under the No Surprises Act. The question after that is, how much more does Congress want for consumers? And if that really is driven by cost, and whether some of these measures are actually impacting that. But I do feel, to an extent, that Congress feels like it's done. and that it's up to the industry participants to kind of come up with those cost savings on their own.
Yeah, I just I really hope it does empower the consumer to take control. I mean, I think I'm 20 years into cost containment and all the different discussions I've had over the years that are typically amongst vendors and administrators and all the people that are behind the scenes wanting to do these things. It's a different reality getting the actual end user to use it, and I think that's what we have to have happen here to really see change.
Well, and that's the key here, right? Is we have listen, we have thousands of new statutes and provisions and requirements on health plans. At the end of the day, how many of those are actually going to impact the consumer, what they're paying, how they understand it, how it's impacting their families? And I want to leave people with this, and I say it all the time, is that we are all part of this narrative, and it's not to rhyme necessarily, it's also imperative for self-insured plans to educate their employees and their families about what these plans do for them, how they operate within them, and the choices that they make. Because we can do this all day long, but unless those employers are educating their consumers more and more, it's all lost. And so this whole, we I think in this industry put a lot of focus on education, and that's really important, but that education also has to waterfall all the way down to the consumer. Because unless that consumer education goes on, none of this really matters, because those decisions and the way families go about doing that isn't going to change.
Yeah, I completely agree. Sometimes the focus is on the one point of abrasion as a self-funded plan versus the 99 points of benefit, and it makes
it's like help us help you help us a little bit. So.
Hey, Katy, in terms of the experience 6 Degrees has had with IDR, what's that look like?
It's actually been going really well for us. I think we have a pretty good success rate on the, that 30-day dispute resolution before going to the formal IDR. And, again, leveraging a lot of different data on those discussions. I think that, I believe from talking with my legal team that both sides do want to avoid the IDR, because baseball style, you win or you lose. And so, you start to kind of think like, if I'm a provider and I'm going to continually hit this and we're paying fees and, this process is going on, I'd rather resolve it sort of amicably, which I think we're seeing quite a bit of. And then in IDR, we've had a great success rate. I think there was only one that sided with the provider, and it was much more about the timely filing of the IDR itself. So, I think that's going well for us. And frankly, I think it's going to be really an uphill battle for these providers to sit and argue that they should get paid more than that QPA. It's far and above Medicare reimbursement or a Medicare multiple. So we are seeing that. And, your cost is, down here at this level, your payment came in at the middle or even closer to the top. And so, the argument really has to be something about what it costs them to provide this service. And when the QPA is far and above that, there's really, it's kind of a hollow argument. So I think that's why we're seeing so much success. I don't know what the overall scoreboard looks like, Ryan, and I don't know if you've heard anything about that, but for us, it's been going really well.
Okay. Ryan, if we see anything out of the federal government this year, Congress, administration, all the folks involved, what do you think it's going to be?
Yeah, I think, over the next couple of months, we're going to see price transparency oversight. Like I talked about, we're going to see drug and PBM reform. I strongly believe that. And, again, keep your eye out. Next Wednesday is going to be a doozy over at Education and Workforce on the House side. It's going to be a slew of self-insured bills, which excites me and worries me all at the same time. So we will see what happens. But I think all that said, I think in the next few months, it's going to be a very healthcare focused activity on the Hill on the House and Senate side. And I think it's probably worth keeping an eye out on, in addition to kind of, some of the regulatory issues that and the court issues that we'll see on price transparency, surprise billing, things like that. So it's going to be a busy couple of months, and I think it's really going to have impacts for the future, certainly for the next like 2 to 3 years.
All right. And one final question for you. How do you think the Washington Nationals are going to finish the season based on the start?
We have to remember I'm a Cubs fan. So I will say this. The Cubbies are much better than the Nationals. The Nationals are going to be rebuilding for years to come. So I was at a Phillies training camp. I was at a Phillies spring training game a couple weeks ago. And the thing that struck me is I was looking at the Phillies roster, and I recognized half of them because they were former Nationals players, if that tells you anything about where the Nationals are now. So go Cubbies.
Could be a long season for you. But
yeah,
since you got your Cubs, maybe still going to be a tough season, I think. Thank you guys for joining us on the Fireside Chat. I don't know, Katy, if you have any parting thoughts, I'll give you a second, and then I'll close things out here.
I'd say go Avs, because we're talking about the Stanley Cup now, and baseball's finals a long way off, so Avs are going to take it again.
All right, I wasn't expecting that one. I thought we were
wow, that was strong, Katy. I like that. Well done with
did
the
not see that coming whatsoever. Ryan's making his contact information available here. It's on the screen. Feel free to reach out to him. Great guy to engage with, and is very, very involved, looking out for all of us through SIIA and all the folks on the Hill. The other thing, for those of you, and no one asked this time, so maybe the message has been heard, but you can watch these recordings on our website. If you go to the cost containment webinars, you'll find links for all of our Fireside Chats. I think we're 2.5 years into this programming, so there's plenty of past content for a long weekend watchathon, and enjoy yourself doing that. And if you want to talk to Katy or I, you got my email, Katy's email, reach out. And with that, we're at the top of the hour. Thank you guys for joining us. We'll see you next month with the folks from Berkeley. We're going to be going through group captives and talking about concepts versus reality. So join us for that one. It's on, I don't know if we have the date set yet, but I know it's in May. So we'll have more information going out to everybody on it. So, thanks, everybody.
Thanks.
Take care.
Thanks, Ryan.
Thanks, everyone. Thanks for having me.